يشرفني طبعا حاليا يعني to present my dear professor Dr. Hamdi Abdelazim for his signature session, the MDT session with all my friends and professors and colleagues. Dr. Hamdi, تفضل.
Thank you, Reem. Thank you so much. It's my pleasure to be with you here with this very, very elegant faculty. So today we're going to discuss practically what we need to know about HER2-positive early breast cancer in an MDT session format. And as you can see, we have on board Dr. Amar Zakaria, Dr. Sharif Najib, the leaders in the country in breast cancer surgery, Dr. Nuran Hussain, Dr. Ashraf Salim, again, leaders in breast cancer imaging, Dr. Manal and Dr. Iman, they are professors of pathology and they are among the very best pathologists in breast cancer once again. And of course, Dr. Hisham Ghazali, Dr. Ahmed Hassan, Dr. Laay, different generations of medical and clinical oncologists, and Dr. Reem, she is a well-known radio-oncologist in NCI, and she's the director in Herman Hospital. So thank you so much for being together today. We'll always remain doing our job together. And this is the very first case we're going to discuss. All the session is HER2-positive early breast cancer patients, non-metastatic patients. So this young lady, 41 years old, family history, father with pancreatic cancer, presented some 2.5 years ago with well-defined left breast cancer, left breast mass actually. And we had this mammography. Dr. Nuran, can you tell us what you see in the mammography? Of course, as you can see, a young woman means yani almost always very dense breast parenchyma. Isn't it that, Dr. Nuran?
Yes, it's very dense. I would say ACRD density pattern. And we can see that the left side is rather shrunken compared to the right, with the large, actually multiple masses seen. I'm not sure if there are microcalcifications. I have suspicions that there are microcalcifications as well, but we can see that the abnormality involves the upper half of the breast, mostly the inner quadrants.
Okay, thank you. So you strongly doubt something happening on the left side?
Yes, definitely,
yeah.
Yes.
That's the MRI of the same patient. Again, can you give us your opinion here?
The MRI, these are post-contrast images, I think, and we have asymmetry, definitely, with the left side also showing a smaller size, shrunken in size, and the abnormality at the inner quadrants mainly showing multiple, almost confluent masses involving the inner quadrants and some skin thickening.
So we need to emphasize, if the breast is severely affected, you'd expect sometimes enlargement in size, but sometimes you can expect shrinkage of the size because of the associated fibrosis. Yes. Okay, that's the MRI, as we have seen. It speaks for multifocal left-sided breast cancer and axillary lymph nodes.
Yes.
Okay, thank you. We'll go to our pathologist. That is the histopathology by H&E. How do you see that, Dr. Manal?
This is H&E photo for invasive duct carcinoma showing polymorphic hyperchromatic nuclei with attempt of tubular formation as well as cores and clusters.
Okay, how do you put the grade here?
I think this is grade 3.
Grade 3, thank you. And the ER?
The ER showing diffused positive strong nuclear staining in all neoplastic cells.
Okay, so thank you. Dr. Iman, what about the PR? Is it strongly positive as well?
It's moderate to strong.
Yeah.
It's less intensely positive than the ER. and also the distribution is less than the estrogen. So it's like 70% percentage, and the intensity is moderate nuclear intensity.
So we're talking strongly positive ER, moderately positive PR,
Yes.
and the HER2?
The HER2 is score 3+. It has a strong, complete membranous staining, and it's in more than 10% of the tumor cells, so it's considered a 3+.
Okay, thank you. I want to remind you that these two ladies are real experts in breast cancer pathology. But the outcome came like this. It is grade 2, which is always the pathology report in the majority of our cases. ER 8/8, we are, and PR 4/8. So it is going with the opinion of our experts for the ER and PR. For the HER2, it was the score 2. And hence, we had to go for ISH, which showed that the HER2 signals over the CYP signals were, we'll go into this, were less than 2. So by ISH, it is HER2 negative. But I want to stop for the grade, because I know everyone in the room doing clinics with breast cancer women, they receive the grade of the disease almost in the majority as grade 2, right? The clinicians? Okay. So the grade 2. I want to tell you that actually it's not our own problem with our pathologist. I will show you how did the best breast cancer pathologist in universe, they are not able to produce the same information when it comes to the grading of breast cancer. The pathologists here, they are of the NSBP group, which is by far one of the most important international groups in early breast cancer. Look at the outcome. They brought 3 expert pathologists in this group, and they provided slides for them for patients with breast cancer. They are all duct carcinoma, infiltrating duct carcinoma. And they provided overall concordance in 43%. So the 3 experts in breast cancer, they were doing the same report only in 40% plus. And look at the discrepancy. For grade 1, the concordance was 36%, grade 2, 23%, grade 3, 61%. But wait a minute. Let's see another more recent report coming again from Yale University and other 2 big universities, including Mayo Clinic in US. And they reported this 1 year ago, doing the same exercise, now with the digitally scanned slide. Can we do digitally scanned slide and reviewing, Dr. Iman, at the present time in Egypt?
No, we don't have yet the digital scanning system, except in very few centers.
And what kind of an advantage if you have digital scanning? What does this provide? Because if it is very important, I mean, if it can really reduce the time of the pathologist, then we may, at least in 1 or 2 institutions, we may think to provide it to our team.
Yes, it has several advantages. The first advantages is, as you kindly mentioned, it saves time. It gives an opportunity for multiple observers so that we can have a more consensus on the results. It also has the advantage of the artificial intelligence system, that the system, the digital system, kind of has the option to learn by itself. And
thank you so much. So,
yes.
So I wish to tell everybody in the room, I am 68 years, so probably I will not be with you when you will witness, everybody in the room will witness the evolution of artificial intelligence in pathology and in radiology. Dr. Ashraf, correct me if I'm wrong. ادوا microphone.
Yes, artificial intelligence is coming among everything
Yeah.
in the whole life. But the first really implementation of the AI was in radiology, and it's now proved by many papers and publications that it has a definite role in high accuracy performance of diagnosing, or at least making areas of suspicion so that the radiologist can follow. There are many, and also which is the area of concern. Sometimes even the best radiologists can really overlook these areas,
Yeah.
but it also proved itself in the dense breast. Nobody can tell me why is that, but there's training of the computer and it really becomes very efficient.
Thank you. So what I need to tell you is something. Artificial intelligence is coming to stay, like your iPhone. It is coming to stay. Importantly, it will refine the fine-tuning of making decision in the areas of suspicion in pathology and radiology. But again, it can help us where in our country we have extreme deficiency in expert pathologists and expert radiologists in breast cancer. So by having the artificial intelligence, this will help the few experts in radiology and pathology to do a better job with their team. So that's why artificial intelligence will be very important. We will have a dedicated session maybe in the coming year of the role of artificial intelligence in pathology and radiology. At least these two areas, they need emphasis. But anyway, in doing this job, we found that the perfect agreement between 6 pathologists, expert pathologists in breast cancer, was even less, was 30%. And again, the worst agreement was in grade 2. Grade 2, always a gray zone in expert pathologists. So don't be really upset if you find the majority are grade 2. We know that they are not essentially grade 2. But anyway, that's our case. That's the MRI. I'm sorry. That's the PET scan of the same patient, Dr. Ashraf. Are you able to see from your chair?
Yes, I can see the images quite well. Now we have the multicentric tumor masses in the left breast, as well as the axillary adenopathy, and even the interpectoral nodes is there.
Yes. So the interpectoral, the subpectoral lymph node you see where we have the red circle, that's again. Dr. Sharif, you think in this kind of presentation, mastectomy is an appropriate decision? I mean, doable? Can you do mastectomy in this patient with adequate margins?
Yes, Dr. Hamdi. I think when the tumor is so extensive in the breast and it involves more than 2 quadrants, it is in both upper quadrants, upper outer, upper inner, and retroareolar. It's too extensive for breast conservation, and I think a skin-sparing mastectomy is due with probably removal of the nipple areolar complex.
Yeah, because the very deep lymph node, as you can see, it touched the real chest wall. Still, it is fine, or it is not.
I'm sorry, I didn't get the question. No, I would rather start with neoadjuvant treatment,
Okay,
of course.
because resectability might be compromised. You need to go so deep into the muscles.
Definitely.
So now we'll go to our oncologist. Our expert surgeon mentioned that in this case, because of the extensiveness of the disease, especially the deeper part of the disease, even mastectomy or radical mastectomy, if you wish, might be compromised. Okay, so we were left with neoadjuvant chemo. Anybody will think of neoadjuvant endocrine therapy in this disease, Dr. Hisham? It is a luminal B, frank luminal B.
Yeah.
KI 35%, grade 3, according to the opinion of Dr. Manel, and it was grade 2 in the pathology report, and very extensive, as you can see.
Yeah, I think also she is 41 years old.
Yes, sir.
So I maybe the best ever decision for this patient is neoadjuvant chemo, because she is premenopausal with this luminal B disease. I think the neoadjuvant chemo is very important. Despite the outcome, the survival outcome is maybe if the surgery is, if she is operable, so the survival is the same, but we may have more advantages for shrinkage of the tumor. We may save the lymph nodes. We may save the lymph nodes if we have complete response in the lymph nodes. But the neoadjuvant endocrine therapy, if the same patient with very old age, we can go for neoadjuvant endocrine therapy, but not in this patient.
So Dr. Hisham, he prefers in this particular patient, she's ER positive, highly positive, PR moderately positive, HER2 score 2, but ISH negative, locally extensive, as you can see. He prefers to go for neoadjuvant chemo. Actually, Ahmad, you agree on that? Certainly. Okay. What kind of chemo you wish to give?
I will give her a standard anthracycline taxane-based chemotherapy.
Anthracycline taxane is practically is a common index for all kinds of breast cancer. You are never wrong when you say anthracycline taxane. You can add, you can modify, but I mean that is the classic tuxedo. Okay, it's always correct in this kind of events. But we prefer actually to give dose-dense AC. Again, you agree on that?
Yes, we've had data and recently also from the ESMO suggesting that even in the luminal subtypes, you can get some added
Thank you so
benefits.
much. Yes, because we were always under the impression more than 15 years ago when we started to have data on the dose-dense AC, which you give AC every 2 weeks with GCSF support. And we have seen that the first generation of data provided superiority entirely in ER negative, not in ER positive. But later on, we have several studies to tell us that it can work as well in ER positive. Till we have the data coming from the Oxford group. And you know, data of Oxford group are always very important actually to read carefully, because this group, the so-called early breast cancer trialist intergroup, they have individual data meta-analysis. So their meta-analysis actually are extremely valuable. As you can see, Dr. Ahmad, again, whether it is ER negative or ER positive, the gain in relapse-free survival is significant. And in even overall survival, the gain is significant. So you can depend on this treatment. Importantly, this dose-dense AC does not increase the risk of cardiotoxicity or neutropenic fever because you give GCSF support, okay? So again, we gave AC times 4, and here we are, Dr. Nuran. That was the baseline, and that was after 4 cycles of dose-dense AC.
Okay.
Always the breast here, it is a prone film, so you see the left side is left, okay?
Yes. So as we can see here, if we compare the baseline image to the current situation, we can see that there is a marked regression in the densities that we're seeing on the left side. We can barely see them today. There is just some edema and slight distortion. So there is definitely good partial response.
Okay. Why the density on the left side, on the right side now is less in the follow-up?
This happens sometimes as a response to chemotherapy, that the normal glandular uptake that happens on MRI
Yeah.
can also regress a lot during chemotherapy.
Yeah, but it happens more with the LHRH agonist because we gave with ovarian function suppression, because we transformed this woman with LHRH agonist, which ovarian suppression, into postmenopause. So it's very important that we take care that nothing happened to the left breast except now the woman, because we always administer in young women LHRH agonists to preserve fertility and to do other things. As you can see, the breast parenchyma is less dense. So the patient was shifted to paclitaxel, and we added carboplatin. Dr. Lai, is that a good approach? What do you think?
Well, for patients who do respond well in the ER positive, HER2 negative, we don't usually add, but in those who have sluggish response on anthracycline.
The problem in this patient, the MRI told us that there is good response, but clinically and by sonography, which I didn't show you, there was no apparent real volumetric reduction. So that's why we had to add carbo. That's not a classic decision. The classic is to give a taxane. And we start like this again, Dr. Noran. Still now the MRI is in the regular image. That is on the left-hand side, the left breast after the original chemo, and on the right-hand side, the left breast after the 4 more chemotherapies.
So we can still see that there is some distortion that's taking up contrast.
Yeah.
But definitely there is an improvement. In these images, we can't see the axillary lymph nodes, but
Yeah.
I'm expecting them to as well have shown some good response.
Okay. So we decided because of that we cannot give further chemo, and she was receiving as well LHRH agonist. So the MDT decision was to go for mastectomy. Do you agree on that, Dr. Amr? Do you agree on mastectomy in this patient?
Yes, I agree.
I'll show you the MRI here.
Yes, first of all, we did not localize the tumors pre-chemotherapy.
Yes, but we did not localize because we were not advised to localize by the surgeon.
It's from the beginning for mastectomy,
Yeah.
and we agree
Okay.
on this, and this is the right decision, yes.
So to our astonishment, the pathologist reported a very large mass in the breast, 8 by 4 by 4, with other foci. So other focus, 1.2 times 1.5, with evident scarring, extensive scarring in the breast tissue, and 2 out of 10 positive lymph nodes. So now I think for the oncologist, you are in a hot soup. The prognosis is extremely poor here. What do you suggest?
First, I wanted to discuss with you, Professor Hamdi, about the carboplatin.
And Isaac, بس على السلايد.
The HER2 positivity, I know. So
Yes.
It is,
It is HER2 positive. Once again, the surgery was done in Gustave Roussy in France, and that's the pathology in France, and that is the final pathology. Once again, Dr. Iman was correct. It was HER2 positive. Okay. Then you wish to give treatment accordingly, but wait a minute. Unfortunately, they went to the US, the patient, to MD Anderson Cancer Center, assuming that's the best that money can buy when it comes to diagnostics. So it was revised. The same tissue was sent from France to US, and in MD Anderson, it was again CISH negative. So I want just to tell you, sometimes you have very contradictory information, even among the very best cancer institution in the whole universe. Anyway, because of this, Dr. Hisham, you believe the American, I know, knowing you. Anyway, everybody, even the French, they believe the American, like in Ukraine. It's exactly the same situation, okay? Everybody has to follow the Americans, okay? So they followed the Americans, and because it is HER2 negative, according to the American definition, we need to review with our colleagues how we confirm HER2 positivity. Sometimes it's not very, very easy. So allow me, with the presence of our pathologist, to review how do you diagnose this. You have HER2 overexpression. Remember, it is not HER2 mutation. So HER2 is not mutant. HER2 is there, but it is overexpressed. So overexpression is the term given for the receptor, while amplification is a term given for the genes. So if it is HER2 positive overexpression, you mean that by immunohistochemistry, you have plenty of brown color at the cell surface. That is HER2 positive +3. But if it is +2, then you have to go for one of the fish, any of the in situ hybridization. You search for the DNA, how many loci of genes of HER2 are expressed inside the cell. Because if it is amplification, then we have more than 2 copies of the gene inside the cell. So either you search for the receptor, for a protein, receptor is a protein, or you search for the gene. Okay, so can you help us, Dr. Manal? That is the green and the pink. In the fish or anything of this kind of things.
This is HER2 fish.
Yes.
The HER2 copies are red, and the chromosome 17 are green in color. Here,
I will stop for a second. The HER2 is located on chromosome number 17. So you want to see how many copies of the gene in relation to a constant expression of certain part of the gene, which is always 2. And this is the centromeric portion of chromosome 17. So the green is a constant, is fixed at 2. And the red is the number of HER2 gene copies. Yes, please, Dr. Manal.
The ratio between the HER2, we have 2 copies of HER2 in each nuclei and 2 copies of chromosome 17. So the ratio is about 1, so it's not amplified.
It's not amplified. So this is no amplification. But what about this one?
We have here clusters of HER2, so this is a case of HER2 amplification.
So we have plenty of pink, too much pink, for 2 green, the so-called SIP. Centromeric portion of chromosome 17. So the ratio here is much more than 2. Okay? So the guidelines will tell you if HER2
if HER2 is less than HER2 chromosome 17 ratio less than 2, it's not amplified, and if HER2 chromosome 17 more than 2, it's amplified case.
But in the latest version, we found that they have added the number of the copies to be more than 4. Not only the ratio is more than 2 or 2, the number of copies should be more than 4 to confirm the HER2 positivity, and vice versa, to confirm HER2 negativity, the ratio is less than 2 and the copy number is less than 4. In either situation, you're sure that this case is either ISH positive or ISH negative. The problem is here. In different other scenarios, which I will not discuss with you, the pathologists, they know it, we have other scenarios that you cannot really swear, is it HER2 positive or HER2 negative? And that's the importance of doing this test with pathologists like these two ladies, where they are really expert how to deal with the tissue because they have certain solutions. They may have second opinion with each other in order to reach a final answer. So sometimes it is a straight answer, yes or no, but in many times it is not as simple as we clinicians may think. Anyway, this introduced the need to have a new term in HER2 positivity, which is called HER2 heterogeneity. Are you ready, Dr. Iman? Yes. This is a case, it's not our case, where we have area of HER2 positive and HER2 low. You agree on that, Dr. Iman?
Yes.
And then another areas of HER2 positive and HER2 intermediate and HER2 strong. So she will write to you in the report HER2 positive because it's HER2 positive. But for you, in your imagination, you have to consider that the areas of HER2 positivity is not universe. Not all the tumor is HER2 positive. We have other areas, HER2 score 2, score 1, or score 0 in the same tumor. Okay, would this lead to poor performance of the anti-HER2, Dr. Ahmed Hassan? احنا الكونكشن راح يا جماعه.
لا
حد يجينا من فضلكم؟
لا
احنا كله هنا اللي قصادي وكله. دكتور احمد كمل يا حبيبي. بنتكلم على HER2 heterogeneity. HER2 heterogeneity, in the first report it happens in 10% of HER2 positive. In subsequent reports it happened in more than 25% of HER2 positive. So this is a reason why certain patients, their response to HER2 therapy is compromised. Okay, Dr. Ahmed.
Yeah, I believe it will affect the treatment outcome. And I think your case, Dr. Hamdi, has demonstrated that in this case, for example, when we have heterogeneity and we haven't offered an anti-HER2 with the chemotherapy, maybe you would have observed better responses if we added for this patient upfront.
Yeah, but as you can see, we have done all our best to confirm positivity in different institutions, including in our institution and in Gustave Roussy and MD Anson. So
it's very challenging, particularly with two very reputable hospitals.
It's very challenging. I think you have to go down شوية كمان. امشي في ماشي أول 20 سلايد من فضلك.
But in such a patient, I don't know if you will agree.
أول 20 سلايد، أول 20. Okay. عايز أوصل اللي أنا كنت فيها. Okay.
I'm not sure if you will agree, Dr. Hamdi, with me or not, but.
Okay, بس شكرا. خلاص كده أكتر من المطلوب. ميرسي يا حبيبي. Okay. So HER2 heterogeneity, as you can see, it happens for many reasons. I will not go into the details of that. But one simple explanation, actually, is that the tumor is heterogeneous itself. Some of the tumor cells, they have amplification of the gene, and in some other tumor cells, they don't have amplification of the gene. But we have some other more complicated reasons. But the bottom line, it is there. The very early reports mentioned 10%, and later we know it's more than 10%. Dr. Ahmed mentioned that this HER2 heterogeneity can be a problem in two things. One is that you might not be able to diagnose HER2 positivity like this patient, and hence you give treatment without anti-HER2, and this can explain the failure to respond to chemotherapy. And another thing is that HER2, as you see, HER2 heterogeneous tumors are associated with significantly shorter disease-free survival if you give anti-HER2. So they do not respond in the same way to anti-HER2, but they still need anti-HER2. Yes, please.
Dr. Hamdi, I know that it is not standard, but do you think that the molecular classification may help or not? So the molecular classification, so we can go for BAM50 or Prosigna or something like this to assess it is HER2 positive.
The molecular classification can help you, of course, to refine, but we don't have real data in HER2 heterogeneous because you compare molecular data against immunophenotyping. They never mentioned that immunophenotyping, but we do not have molecular data for patients with HER2 heterogeneous disease. Okay?
Because I have one patient like this, and we go for BAM50, and she was HER2 positive. So I went for anti-HER2 treatment. But we discussed with the Frederic Benelorca, and she told me that there is we cannot go for concordance between
but
both.
in metastatic disease, please don't forget that if you go for PAM50 for ER positive HER2 negative verified, you will find something like 15% HER2 enriched by PAM50. So because PAM50 is a genomic platform, and in genomic platform, you have the average expression of so many different genes, okay? But anyway, HER2 heterogeneity is a reality. It is associated with mistakes in the diagnosis of HER2 positive disease. And if you diagnose it, still patients with HER2 heterogeneous breast cancer, they respond less favorably, especially if you give antibody drug conjugate therapy like TDM1. And we have seen in a beautiful study later on that if you give TDM1 in the neoadjuvant phase, and in this particular study, they have done two things which we can do in research with our pathology group. In the same patient, they have two biopsies from two sites in the breast cancer before neoadjuvant treatment. And they compared the two biopsies against each other. Dr. Manal, can you tell us, in the left side, that's the same patient, left and right side. But in the left side, you can see the amplification of the HER2 gene is amplified or not amplified?
Not amplified.
It's not amplified on the left side, while on the right side, it is
amplified.
It is amplified. So you see much more red color in the right side compared to the left side. That's the same patient. And they found this in 10% of the population that you treat, and they will all receive TDM1. And as you can see, the PCR rate in patients with HER2 heterogeneous disease was 0 versus 55% if it is HER2 non-heterogeneous. Anyway, we'll go back to the patient. We revised the pathology at MD Anderson. They told us it's not HER2 positive. So the patient received postoperative radiation and maintained on LHRH agonist plus letrozole. Do you agree on that, Dr. Luai?
Yes, but while considering her as a HER2 negative, we
because the Americans don't forget Ukraine, okay?
So
Americans said it is HER2 positive, negative, then it is HER2 negative. By the way, in Gustave Roussy, where her surgeon was, he told the patient, okay, MD Anderson, they have the best lab.
I think we can go for these patients.
BRCA testing.
Yes.
I think to go for BRCA testing while
BRCA, I forgot. BRCA was negative.
Okay.
Yeah, BRCA was negative. Yeah.
So you agree for this or to add?
To add the abemaciclib then.
Abemaciclib was not approved at that date. It is 2021 early. Okay. So anyway, after on March 2021, she relapsed very early, and as you can see, Dr. Nuran.
Okay, so this is her follow-up PET-CT, and we can see a deposit in the right iliac bone, and there's also one of the vertebrae. We can see that there's a deposit in it as well.
Okay, so you'll put it as confirmed
metastasis.
diagnosis, confirmed metastasis?
Yes.
Yes, confirmed. Dr. Ashraf, where do you wish to put your needle actually here?
You mean in any
We don't
bone
have
met-
any soft tissue lesion, okay?
Yes, I can take from the iliac, from the right iliac bone. It's much easier. It's
Okay.
larger, and it's safer in a way or another.
So that's what happened, and actually it was Dr. Ashraf who took the biopsy, and the biopsy came like this: ER 6/8, PR 0, HER2 score 2. Once again, KI 20%, and that's our local pathologist. It was +2, and it was CISH positive, and this was revised in MD Anderson to take the blessing that it is HER2 positive, and they, alhamdulillah, mentioned that it is positive. So congratulations. So you see how far we went wrong in the treatment because of the HER2 heterogeneity. And how do you wish to treat her, Luay? Now. You wish to send her to Reem to give radiotherapy here? It is not symptom producing. We don't have any pain.
So no radiation.
So
That's
I'm
about-
sorry, Reem, no radiation in the, okay. Then how do you wish to treat her? Now it is HER2 positive with the blessing of Joe Biden. Okay.
So now as she's anti-HER2 naive, so it better go for dual blockade as a first line, Cleopatra-like protocol.
In conjugation with chemo or with endocrine therapy, remember she received the very heavy chemo less than 1 year earlier.
And she relapsed also on less than 1 year of endocrine therapy. So
thank you. That's exactly what we did, because this was actually encouraged by the PERTAIN trial. The PERTAIN trial compared the endocrine therapy plus trastuzumab, that the blue curve, versus endocrine therapy plus pertuzumab and trastuzumab, that's the yellow curve. And as you can see in this kind of patients, especially those with low tumor burden, you can expect very, very impressive progression-free survival. So that's what, according to that, we did start the endocrine therapy plus pertuzumab, trastuzumab, and that's how she's performing more than 1 year, almost, and 3 months. Dr. Ashraf, are you satisfied with the outcome?
Of course, as everybody can realize that there's no uptake anymore in the recent study, whether it's the iliac bone or the dorsal vertebral bone.
Okay. Do you have any take-home, conclusion from our faculty here, other than this? The importance of diagnostics in HER2, it's not that difficult, but it's not that simple at all, okay? Our pathologist or radiologist, you wish to add anything?
Yes, just for discussion for the pathologist. We know the HER2 is heterogeneous disease, and the failure to what we saw in this case, does it really, because of the narrow field that we do the pathology specimen, I mean, we look at a certain part of the tumor, not all the tumor. And I know that there are in the literature now publications talking about the 3D macrohistological studies that can really see the whole tumor pathology in a microscopic way, and we can do all the analysis for the HER2 expression. I need to know is what I'm saying is correct.
But I'm not aware that this is not in the guidelines as yet. But
I'm
certainly it can give more expansion
the 3D
of the field of vision.
macrohistology. Would it be good for these complications?
It's usually not the everyday practice having the macro sections, but we usually do embed the whole tumor. The whole tumor is embedded, and usually breast tumors are not that big, so it's easily to embed the whole tumor. And especially if we have multicentric tumors, we have to examine all the different
pieces,
foci.
just
Yes.
small areas, not the whole together.
No, not the whole together. We
Yeah.
take the
Why I'm
different-
saying that, because you mentioned that the Americans have the latest technology. That's what I'm talking about, the 3D macrohistology. That may be the clue for, reaching the accurate diagnosis for the HER2
Because
heterogeneity.
this
Maybe.
can be better if you wish to check on the gross picture when it comes to microscope, because they have to section for the microscope, they have to do sections.
Yes.
But once again, thank you, Dr. Ashraf, for this piece of information, that we need to understand that the technology in the future will be more and more refined to provide better insights of what's happening into the tumor, whether in the radiology or in the pathology field. But for the sake of this discussion, that we have guidelines, very strict guidelines by the CAP, College of American Pathologists, and with the ASCO, to put the threshold for HER2 positivity. But still, the term HER2 heterogeneity has been recently introduced, and it is a real problem for the diagnostic pathologist, and again for the oncologist. Probably in patients with HER2 positivity, heterogeneous positivity, probably I wish to give more chemo plus anti-HER2 rather than antibody drug conjugate like TDM1. You agree on that, Dr. Luai? Yeah, okay. So we'll go to case number 2, another tricky case. A very young lady, 29 years, swelling of the left breast. She was known to us as a BRCA2 carrier, because she had to undergo this test several years earlier for the whole family. She had 2 maternal aunts with breast cancer. One of them was at an early age, and one maternal uncle with prostate cancer. So she was known by prior examination to be BRCA2 positive, and that's how she looked in the profile. And Dr. Nuran, that is the mammography. Anything to write home about?
There's like a diffuse asymmetry in the right breast.
Yep.
We can see it on both views, actually. I can't see any definite masses, but there definitely is a very big asymmetry. And knowing that she's a BRCA positive and her age, I would ask for an MRI.
Okay. That's the mammography. That's your work.
That's
once
the
again,
ultrasound.
Dr. Nuran. Okay.
Okay, thank you.
That the ultrasound,
Yeah. So
and
the
that is the biopsy. In the ultrasound, I'm sorry, we needed to show the report. That's the report. Diffuse nodular
yeah, there's a
heterogeneous
lot
texture.
of heterogeneous texture with like a large area of distortion, and it's not usually, these cases are very difficult to measure, so that's
Yeah.
why they need an MRI.
So I'll bring you the MRI in a second. So the pathology, it was duct carcinoma grade 2, ER4/8, PR0/8, HER2 score 3 straight this time, KI 18%. And my question to the oncologist, what do we know about HER2 positive breast cancer in women with BRCA mutation? Because we always say that if you have BRCA1, the majority will be triple negative. Around 75% of patients will be triple negative. But if you have BRCA2, the majority will be ER positive, HER2 negative. We never mentioned HER2 positive in BRCA mutation, did we? We don't, right?
It is rare in
Yeah.
it's the least.
It's not really rare, but it's, as you say, it is the least phenotype.
phenotype
Yes.
in BRCA positive.
Okay, so to find BRCA positive, HER2 positive is possible, of course, but it's not very common. Okay, one of the early reports to tell us so is the Manchester group published several years ago under a very frank title, Low Prevalence of HER2 Positivity Among BRCA Mutants. So they are put their conclusion into the title, and the data were pretty convincing that in BRCA1, the HER2 positivity was 2%. In BRCA2, it was a little bit higher, significantly higher, but again, it was around 7%. And then the POSH group in UK, this data this time is prospective data. They found in BRCA positive women less than 40 years, they collected around 2,700 patients, and they found HER2 positivity in 7% if it is BRCA1, 11% if it's BRCA2, 30% if it is BRCA wild. And later on, the Italian group have done similar exercise that's a national data from Italy. They collected 400 patients, all with BRCA mutation. HER2 positivity was 7%. So it is less. And they have done another exercise. They have done meta-analysis of all the studies in the world till last July, and they prevented that HER2 positivity in the meta-analysis is 9%. So you can put it like this way. If your patient is HER2 positive, if your patient is BRCA positive, the likelihood of being HER2 positive is around 9%. But if it is BRCA negative, HER2 positivity will be something like 20%. So it is half of the cases, actually. And always BRCA2, they have higher HER2 positivity than BRCA1. But in this publication, actually, which published 3 months ago, they discussed two important things. First, what kind of data we have for PARP inhibitors in patients with HER2 positive. Dr. Ahmed Hassan.
I think we have very limited data if we have any.
Yeah, if any. We have very limited, if any, because actually PARP inhibitors, as you know, they are approved only in HER2 negative. And all the studies, HER2 positivity was exclusion criteria. So everybody with HER2 positive disease was excluded from the studies with PARP inhibitors. And you always remember in HER2 negative, PARP inhibitors in HER2 negative, whether it is early or metastatic breast cancer. So we don't have data, but again, we don't have nothing to prevent that you may try your lucky stars if your patient fails everything and she's BRCA mutant to give her a PARP inhibitor. Likewise, what is the efficiency of anti-HER2 therapy in patients with BRCA mutation? Dwight?
Well, we would think she would respond.
We don't know. We don't know.
No.
If it was something to be known, you should have known before, because all the patients, all the trials with anti-HER2 therapy, they never put the subgroup analysis according to HER2 mutation, yes or no. Okay? So accordingly, we do not know. But you have to remember that during the last few years, we started to understand that BRCA positive breast cancer, if they are estrogen receptor positive, they do not respond well to endocrine therapy. Which means what? Which means that the presence of BRCA can really do some silencing of the ER signaling. So it can weaken the ER signaling. And so you may raise the same question, would the presence of BRCA do silencing of the HER2 pathway? The answer is we don't know. But 2 weeks ago, we have this beautiful data coming from intergroup between the French in Gustave Roussy and 3 Italian universities. And they put out this data, which is for the first time to be published, that is HER2 positive BRCA mutant, the blue curve, and that is HER2 positive BRCA wild, the red curve, and the difference was significant, and everybody received trastuzumab. So now we have to take care, at least, that we don't know actually the performance of our treatment, but we have data to tell us it's not the best outcome. A co-occurrence of BRCA mutation and HER2 positive, that's the conclusion of the study, is a poor prognostic factor in patients with early breast cancer, okay? And that's the situation of our patient, actually. At the present time, we have ongoing study to give trastuzumab plus olaparib in this population in the metastatic phase, but still we don't have data. Now we'll go back to our patient. That is the MRI, Dr. Nuran. It took us time to bring it to you.
Yes, so this is a maximum intensity projection image, which gives like a 3D image of the breast. And we can see that there is a large area of non-mass uptake involving most of the breast, especially towards the outer quadrants.
Yeah.
And non-mass uptake is associated with HER2 positive patients. We see it a lot. I think there are quite a few level 1 pathological lymph nodes as well, but we need to assess them by ultrasound.
Dr. Ashraf, when I know it is HER2 positive, should always I go for an MRI? Is it an indication in the neoadjuvant setting to do MRI in HER2 positivity?
Yes, definitely. This is a very strong indication for the proper size, because most of them are really non-mass lesions, diffuse. Of course, the multifocality and multicentricity, this is an issue as well.
Yeah.
So, and also in the follow-up, we have a baseline study.
Okay, and now please, we'll have a look once again for the MRI. Remember, the mammography was not conclusive, and the ultrasound, it mentioned nodularity where we had the biopsy. But when you have an MRI, all of a sudden, you are confronted with a huge thing, which we call non-mass enhancement. There is no really regular boundaries, as you can see. That's why it is called non-mass enhancement. So the enhancement itself is a sign of malignancy in this case, Dr. Ashraf. The extensive enhancement with the rapid washout.
Yes, of course, we see the whole picture, the morphologic as well as the kinetic data, and we can assess that these are the what we call the BI-RADS 4 category, and it has to be biopsied, of course, and this goes with the HER2 positive tumors.
Dr. Sharif and Dr. Omar, is surgery here doable? Mastectomy? You can do mastectomy here, right? I mean, theoretically speaking.
No, we will definitely start with neoadjuvant treatment.
Yeah, I know. Yes, sir.
But
no, I mean,
even
technically speaking. Yes. Is it doable?
It is doable, of course.
Okay. So it is not inoperable. That's what I want to tell everybody. We don't do surgery not because it's inoperable. Because actually the first case was probably inoperable, but this patient is really operable. But we don't go for surgery because we have in the MDT, we have to make the decision that she has a lot of medical therapy to help this lady to be better. So after the MRI, as we have seen, she's now T3N1, HER2 positive, germline BRCA mutation, ER positive. So we have a lot of things. We treated by trastuzumab, pertuzumab, paclitaxel, carboplatin. The 3 oncologists in the room, 4 oncologists. You agree on this decision? Okay, so non-anthracycline treatment, and that's how it goes clinically. You see any difference, Dr. Hisham, between December 2020 to March 2021?
I think there was the lump and the retraction of the nipple in the first picture, as I remember, and now is much better. So I feel that she has a very good response after 4 cycles.
Clinically she had, and that's radiologically, Dr. Ashraf.
Yes, remarkable regression of the diffuse enhancement of the non-mass enhancement. Of course, before and after is quite obvious.
But in the whole dimension of the non-mass something, it looks still there.
It's still there. Of course, it is not a complete remission.
So it's only the difference in enhancement, not in the tumor bed
extension and
itself.
the size, yes.
Yes. So that's the importance of having good radiologists with you in order to tell you that it looks better, of course, but still you still have the regression is mainly not in size, it is dramatically in the uptake of the contrast. Okay, thank you. So you will keep under the same treatment, Dr. Ahmed?
Yes,
The
she-
radiologist is happy about the response. He will tell you, I'm satisfied.
She's responding. So
She is responding. Then that's after another 4 cycles. That's how it goes. Dr. Ashraf, still that's,
Yes,
we need your opinion
I
now.
mean, the size, globally speaking, the size, I think this has definitely some regression,
Yeah.
although there are some remaining foci of enhancement still there. But of course, the regression here can be concentric regression or fragmented regression in
Yeah.
a colon. But
That's
still, there is
fragmented
a
regression.
tiny
That's very
lesion still
important because actually we have to discuss with the surgeon what kind of surgery should be done in this patient. But just to review, that was the baseline and how it goes. Radiologically, Dr. Ashraf, you put it as complete response or residual disease.
There is still some residual disease. Still
Thank
there.
you.
Professor
Now
Hamdi-
the question for everybody, okay?
Professor Hamdi,
Dr. Hisham, yes.
Do you think I know that this is extensive from the start, and usually I think we decide from the start that the surgery may be not a conservation, but do you think it's better to have like a mark or to define the places of the tumor to the boundaries?
If you that's the baseline. I mean, how do you wish to mark actually?
Yes.
I'll show it to you the baseline. The baseline on your right hand side, there is nothing to mark actually, okay? And even if she's not BRCA2 positive, and now that's the end. By the end, if you wish to mark this, you can do that, of course. But we have to discuss this in the MDT, and now we have our surgeons, our radiologists, our oncologists, and the decision. What kind of surgery? Dr. Omar, difficult question.
She's a candidate for a skin-sparing mastectomy and
Yep.
sentinel lymph node biopsy with immediate reconstruction. She's
Yes,
young.
but you have to take the opinion of our radiologist. Is the skin nipple complex is fine now?
I would like to show you from the beginning, and I was telling Dr. Sharif, please look
Yeah.
at the perforators, the blood supply coming from the medial part of the breast. You can delineate the skin, and you have a very nice plane between the skin and the tumor on both sides. So I think, yes, skin sparing is a very good
A wonderful
option
answer.
here.
So
A
bilateral
wonderful
or-
answer. That's
I won't
one
do
of the good
bilaterally
things
now.
about MRI and the great thing about the MDT, that this kind of extreme, I mean, refined observations can be made when you deal with such an expert team. Okay, thank you for the answer, because it was from the beginning, and this as well goes well with the naked eye. That's the naked eye. Okay, so the nipple error complex by examination and by observation. Sometimes observation is very important. I mean, inspection is very important. It didn't seem altered, and with subsequent, I mean, response, it became more and more secured. So the question of to go for nipple sparing mastectomy, nipple and skin, of course, sparing mastectomy is crucial, because the nipple and skin are the best form of nipple and skin reconstruction is to use what has been made by God, the skin and nipple and areola made by God. Okay, Dr. Ashraf.
We are talking about the nipple and the areolar sparing or not. So we have to define, what do we mean? Do we mean the subareolar area or the nipple itself and the area? And how far can the distance be when you decide? I mean, is it half a centimeter? Is it a few millimeters? Because the subareolar area is really the rich area that has all the plexus, the sapay plexus of lymphatics and so on. I mean, what do you need so that we can help you in assessing this area?
Yes, certainly, Dr. Ashraf. But because of we cannot provide all the cuts for every part of, and Dr. Ashraf is emphasizing the importance of appropriate reviewing of the nipple error complex by the radiologist in the MDT before we confirm, before we swear for the negativity. But it was in the report, original report, there was no involvement in the nipple error complex. Yes, Dr. Amar.
Technical parts for Dr. Ashraf, we do coring for the nipple. There is no residual breast tissue. We do not leave any breast tissue. We are doing coring of the nipple itself from inside to make sure that the ducts are removed. But again, if you look at the MRI pre-chemotherapy, you can see there is a plane behind the nipple and the blood supply is reaching the nipple very well. I can see it. So I think she deserves the trial with the presence of pathology intraoperative.
Yes. And of course, with the presence of intraoperative pathology, this goes without saying. Dr. Hatem, you wish to give a comment here? Okay. So, the answer was, as you mentioned, Dr. Omar, she had the nipple sparing and skin sparing mastectomy with latissimus dorsi flap, and the histopathology, it was PCR. That's how, this is, I think, Dr. Sharif Naguib case, and this is how she looked after the end of radio. I think you have done this case, Dr. Luai. Now we have 4 questions important to answer. Adjuvant endocrine treatment. What kind of adjuvant endocrine treatment you wish to give, guys, oncologists? She's 29 years. HER2 positive in PCR, ER4/8, PR0, HER2 positive.
And BRCA mutants.
You will give?
And the BRCA mutants. This patient is BRCA mutant.
BRCA mutant, yes. But BRCA will not, at least in this case, will dictate the answer. Yes, BRCA mutant.
I will go for to continue the LHRH with
AI
aromatase inhibitors, and then we go for to continue the treatment with anti-HER2 dual blockades.
So the classic soft and text data, you will apply the soft and text data, LHRH agonist plus an AI. We have some, retrospective data to tell us that probably aromatase inhibitor is superior to tamoxifen in HER2 positive. It's not very strong data, but it seems to be like this. Luai, Ahmed Hassan, any comments?
No, I would do the same.
You'll do the same.
I do the same. I start the same, but we have a very good chance to manipulate the endocrine therapy as we go, because the benefit of endocrine therapy might not be the same in this patient for the HER2 and BRCA as well. So if she wishes to de-escalate the endocrine therapy after a while, it's a good option.
So Luai prefers to do some de-escalation later on for the LHRH agonist not to be for 5 years. He liked so much the Korean people, and we have a study from Korea, not North Korea, it's South Korea, to tell us that 2 years of LHRH agonist can do similar benefits in these women, although the guidelines will tell you 5 because the history is made by the Americans once again, okay? Anyway, that's adjuvant endocrine therapy. You may have a room for de-escalation of LHRH agonist according to the Korean study to 2 years only. Contralateral mastectomy. Dr. Sharif, she's BRCA2 mutation. Let's have a look on her risk for contralateral disease. It is in the range of 26% over the coming 20 years, and if she has BRCA1, it is even more. But we have other more problematic thing, which is the adnexa, and again it is much higher. The ovarian and adnexa much higher. It is BRCA1 versus BRCA2. Remember, she's BRCA2. Do you wish to go for contralateral mastectomy in this patient during same surgery or probably later on?
Actually, there is a controversy concerning the management of the BRCA mutated patients regarding the normal breast. So some people advised prophylactic skin risk-reducing mastectomy. Some people advised the use of chemo prevention or hormonal prevention in the form of tamoxifen. And some others advised only very close follow-up. So it is controversial. But the thing I can assure you is I would rather not do a mastectomy immediately and synchronously with surgical treatment of the diseased breast.
Yeah.
Because after radiotherapy, the target breast changes in position and in size. So if you adjust or if you try to symmetrize the contralateral breast immediately in the first surgery, you find discrepancy after radiotherapy. So I'd rather probably wait and do another symmetrization procedure after radiotherapy, at least by 1 year.
So thank you for the answer. Very, very clear answer. If I'm going to consider talking about contralateral prophylactic mastectomy, I will not do it now. In US, there was and still a very strong wave in favor of doing bilateral mastectomy and immediate reconstruction bilaterally. And now we have more wise surgeons. They are talking the same language that we heard from Dr. Sharif Naguib, that don't do it right now. Your patient should finish her prescribed radiation therapy, because after reconstruction of the involved breast, and then you give radio, the shape of the reconstructed breast will change. Certainly it will. And hence, if you wish to consider contralateral risk-reducing mastectomy and immediate reconstruction, do it after the end of radiotherapy on the affected side. Thank you for the answer. And we have seen, of course, a lot of it's not a very always a very nice rose garden, the contralateral mastectomy. These photos are provided by Dr. Krishna Klu, who is one of the world leaders in this field as a surgeon. And immediate reconstruction can lead to several problems. Of course, our surgeons, they are aware about that, and even chronically they can lead to implant what we call capsular contracture. So you need very good surgeon, and you need again good luck to not to have problems. So the early the breast cancer in young women intergroup, they emphasize that this should be done by a dedicated breast surgical team. Not any surgeon can be really approaching can approach this kind of treatment decisions. And they emphasized, as our experts told us, skin and nipple and sparing techniques should be adopted, which is again not very difficult, but it's not easy at all for regular breast surgeon. It needs a certain experience. If contralateral mastectomy is denied, Dr. Nuran, can you give us some solutions? If your patient told you, I'm not going to have bilateral mastectomy and immediate reconstruction now or ever, I'll have one in the diseased area because we have to do that. But in the contrary, leave me my breast because I'm only 29 years, okay, then, do you have solutions for that?
We should do a proper follow-up annual screening with
Proper
MRI.
follow-up as of?
MRI.
MRI. So
yes.
MRI, how did we know that? We know that from 2 consecutive Canadian trials that showed us if you use MRI in the follow-up of your patients with BRCA mutation, in your left hand side curve, that's stage 0 and 1 detection. The MRI is the yellow, the mammography alone is the blue. And in your right hand side is stage 2, 3, and 4. So as you can see, if you utilize MRI in the follow-up, as mentioned by Dr. Nuran, the likelihood to diagnose early contralateral disease in BRCA mutant population is significantly higher compared to other detection modalities in patients with breast cancer. And in the subsequent year, by the way, another group, again, always from Canada, told us the very same. And even if your patient is postmenopausal with non-dense breast, the MRI can detect earlier disease in BRCA mutant population. So the take-home message, very clear. If your patient and you as a treating oncologist, you decided not to consider prophylactic contralateral mastectomy, then you have to go to Nuran to do you an MRI. That's how it goes. You do that in Hermel, ya Jama'a?
No, we don't have an MRI in Hermel.
We
MRI
don't have in
breast.
Hermel.
We
Okay.
don't have the MRI.
We do that in Asr al-Aini?
Yes. Yes.
As an alternative, also the contrast mammo.
Contrast
Contrast
mammography.
mammo. Okay, you can do that. You can do, but we don't have data for contrast mammo here.
Yes.
But I mean, we do it in NCI, Dr. Sharif or Dr. Amar. You do follow up for BRCA mutant by MRI, because actually in Hermel, which is a hospital which I'm very proud of, actually we still lack some equipment, including MRI. But anyway, you have to have MRI support, whether in your institution or you outsource from another institution. Anyway,
may I just do an emphasis?
Yes.
That MRI should be in addition to mammography, not replacing mammography.
certainly. Mammography is bread and butter, okay? So don't drop mammography. The radiologists, they don't like this, okay?
عشان
Certainly add on.
الcalcifications بس.
It's an
For the
add-on.
calcification.
It's an add-on, certainly. To consider bilateral prophylactic salpingiovarectomy, Dr. Ahmed Hassan, do you need this?
Well, I would discuss with the patient, but she's 29 years, and we know from the data that, particularly with BRCA2 mutations, that the likelihood rise of getting cancer in the ovaries rises exponentially from the age of 45. So we can actually defer this for now. We have 2 ongoing trials. We have one ongoing trial called Prospect or Respect, which is looking at excising the tubes first, because this is more likely to get the cancer at the beginning, and delaying oophorectomy for the patient to enjoy her estrogen levels. And we have another UK study which was conducted in 13 centers for those who refuse the prophylactic salpingiovarectomy. It's called the ALDO study, where they looked at checking frequently the CA125 and doing transvaginal ultrasound for some patients as an alternative, but not as a gold standard.
Okay. So here, Dr. Ahmed, thank you. Beautiful answer. I wish to review his answer with you. First of all, prophylactic bilateral salpingiovarectomy. Does it improve survival? The answer is yes. So when you have a decision, therapeutic decision, that will improve survival, then you have to take it seriously. But look at this. Would it improve survival because it will prevent the second primary in the ovary? The answer is certainly yes. Okay. But would it improve survival because it will also decrease the rate of contralateral breast? The answer is yes. So it does not only improve survival because you remove the ovaries so the patient will be safe from second primary in the ovary. What is important is that if you remove the ovaries, then you will decrease the likelihood of having a second primary in the other ovary and dying of the second primary. So bilateral salpingiovarectomy is very, challenging, because when you do that in younger women, you'll introduce permanent menopause, which is very bothering to the patient. And if the patient is not has not finished her family planning, then you will deprive her from being pregnant. So it's not, the decision is not that easy. And Dr. Ahmed put some ideas about how we minimize the problem of bilateral salpingo ovarectomy. And the most important doable thing is don't do it by all means before the age of 40 to your patients, probably 45. But before the age of 40, probably you don't need to do it. But you need to know that patients, especially BRCA1, can develop second primary in the ovary quite often. Okay, how did we know that? We know that from so many studies, but please look at this table. That's one of the pioneering studies to put priority in BRCA mutation, prophylactic surgery. Breast cancer specific death is reduced, breast cancer specific death is reduced by bilateral ovariectomy, which means it does not only work for the ovaries, it works for the breast cancer specific death, and so is contralateral mastectomy. But for all causes of mortality, whether from the ovary or from the breast, the only thing that will do this is bilateral ovariectomy. Importantly, don't delay it after 50 years, because if it is after 50 years, it doesn't really work. So you have to consider it between the age of 40 to 50, and that's what was recommended by Dr. Ahmed. Do you consider pregnancy, Dr. Luay? She has BRCA mutation, she's never pregnant, and would pregnancy bring bad news for her, activation of her disease, these kind of things?
Well, regarding the cancer relapse, no.
Yes,
And
so it does not increase the risk of relapse. Thank you. And
she might have difficulty in getting pregnant because the ovarian reserve might be a little bit less, and she did receive.
Thank you so much.
chemotherapy.
Because patients with BRCA mutations, they have poor ovarian function for some complicated reasons we can discuss if you wish after the session. But they have menopause even if they never had breast cancer. They have earlier menopause. Their ovarian function are limited compared to patients with no BRCA mutation. And we have learned that from different studies from our colleagues, the gynecologists. And in all the studies that compared the age of menopause in patients with BRCA mutation versus no BRCA mutations, no cancer, they reported that BRCA mutation, they have earlier menopause. But in patients with breast cancer where you give chemo, and your chemo will induce ovarian function suppression as well. We have this nice study done several years ago, around 10 years ago. It is a database of more than almost 2,000 patients, breast cancer in women, young women less than 40, and see if they have received chemo, the rate of permanent loss of menstruation is pretty high. Where when they 35%, when they do not receive chemo, the rate of long-term amenorrhea is only 5%. So again, your chemo will add burden to the ovarian function of your patient, especially so in BRCA1 more than BRCA2, but it happens in either case. Dr. Luay, why do you give LHRH agonists to these patients? What is the idea beyond it?
Well, the ovarian, the typical ovarian stimulation during the menstrual cycle might expose more oocytes to the chemotherapy. So when we stop ovulation, that decreases a little. So in theory, you might save some ovums. In addition, it also the ovarian inhibition saves the ovarian tissue secreting the hormones. So giving LHRH agonist during pregnancy decreases the premature ovarian failure rate, and might also improve the fertility rate.
So we'll stop at the first point. Allow me, Dr. Luay, if you give LHRH agonist before chemotherapy, you can really reduce the rate of premature menopause. And we have known that from this meta-analysis and other meta-analysis, but this is the best one, that if you give LHRH agonist, as we do in our young women, before the startup of chemotherapy, the rate of premature permanent ovarian insufficiency will drop from 30% if you give chemo alone to 15% if you give chemo plus LHRH agonist. Would that improve fertility? The answer is yes. This will increase the fertility by almost a factor of 80%. So in young women, the cheapest way to keep fertility actually is to give LHRH agonist. That's important. But would you allow for pregnancy in germline patients, germline mutations? Dr. Luai told us yes, because of this very large data in patients with BRCA mutation, breast cancer, and they allowed pregnancy. And as you can see, if they have pregnancy yes versus pregnancy no, the survival is the same. And finally, that's the conclusions of our second case. HER2 positive breast cancer is not common among BRCA mutation carriers. And a recent report suggested inferior survival of these patients versus HER2 positive BRCA wild type. In BRCA mutant patients, there is a lot of questions that you should discuss with your patient. And among this, the age to do prophylactic bilateral salpingio-ovarectomy, that's a very drastic surgery, although it is simple to do, but the consequences for the psychological and physical consequences on women, it is very, very severe. And now we are curing more and more breast cancer women, actually. So we have to pay attention to the quality of life of young women who are going to be cured when it comes to fertility. And hence the term oncofertility is strongly introduced into the medical literature, where the oncologist and the gynecologist, they have to collaborate together. And for those of you who are going to attend the San Antonio this year, you will find the outcome of a very important study that is interrupting the endocrinal therapy. If you have a patient ER positive ER positive early breast cancer, and she is receiving adjuvant endocrine therapy, and she wishes to be pregnant, can we interrupt the endocrine therapy to allow for pregnancy? This is a very daring question, actually. And here we have, that's the design of the so-called positive trial. And you will hear during San Antonio very, very encouraging news about interruption of endocrine therapy in the adjuvant endocrine therapy after 2 years, and to allow for pregnancy. That's the second case. Do we still have time, Dr. Reem, for a third case? It is already 2 o'clock. I think we can open discussion, because we don't want to go too late for your conference, and the discussion for everybody in the room. We discuss anything related to early breast cancer, HER2 positive or non-HER2 positive, BRCA mutant or non-BRCA mutant. You have the best experts in the country to answer your questions. We have questions in the floor or from the podium.
Yeah,
it's your
Dr.
case. It's your call.
Hamdi, I think in this young lady with 29 years old, if the response is like onion peel response, so I want to ask the surgeons, do you consider again to go for subcutaneous mastectomy in this patient, or you can go for only conservative surgery? Yes. If you have, despite this large tumor at the beginning, if you have a onion peel response,
I don't think that I would look at it as a single
I'll put you
mass.
and
she's 29 years
Dr.
old.
Omar?
BRCA1, 2
I'll put you the picture. Here we are.
So the patient is 20.
That's the picture. That's before and that's after. What's your question, Hisham?
Yeah.
Is to go. Why not to go for breast saving surgery if she's BRCA non-mutant?
Yeah. If the patient is BRCA non-mutant, and the patient is only 29 years old, and if we have a very, very good response, why you go for subcutaneous mastectomy? You are treating on the original size or the residual size. if you have this onion peel pattern of response.
This is not a mass.
عمر ممكن تعلي الصوت عشان
This
زمايلي
is
يسمعوا؟
not a mass. We are not dealing with a mass that
Yeah.
shrinked. This is an area occupying almost 3/4 of the breast. I cannot even, I will ask my radiologist, this cannot be localized. This is a non-mass.
Yeah, we knew afterwards that it was PCR, but I mean, you cannot be sure that you don't have residual microscopical disease within the breast because it's not an onion peeling as we wish to see that the mass is shrinking concentrically. It is fragmentation of the disease, Dr. Hisham. It's very tricky. I know it turned to be PCR, but we cannot really be sure about this. In radiology, the Dr. Ashraf told us that we cannot be sure that is complete remission radiologically. Dr. Nuran.
If we are going to do conservative for this patient, then we were supposed to put clips.
Yeah.
When
Yeah.
we have a mass, we put the clip in the center of the mass.
Yep.
When we have a non-mass, we have to put the clips in the margin of the mass.
Yeah.
So of the area, I mean. So the clips will stay on the outline. So all this area anyway has to be removed. It's not the same as when it's a mass and it shrinks.
Yeah, yeah.
I think there is, I believe there is a very interesting study which is looking at patients who had a very wonderful response to neoadjuvant treatment. And after taking random biopsies from the area and we cannot detect any viable tissues, whether some selected patients can have radiotherapy and spare surgery, but this is investigational. This is not.
So in order to play it in as safe as you can, mind you, intraoperatively, the pathologist, even the best pathologist in the universe, cannot take all the adequate sections intraoperatively. You need, in this case, Dr. Iman, Dr. Manal, can you tell us how many sections you need to do in order to tell the treating physician about no macroscopical residual disease?
We have to take 1 centimeter from every centimeter of the original tumor.
Yeah.
So if this tumor like 12 by 10 centimeters or something, we have to take like not less than 15 blocks.
Yeah. So it's very tedious. It's very tedious. So many sections in different areas. And in some, the lower cuts probably you need to do it on 2 slides because the fragment is very lengthy. So that's the importance of having, I mean, therapathologists in order to swear that we do not have residual disease here.
Dr. Hamdi, I have a question regarding the HER2 heterogeneity. I mean, what do you do in your practice when you have similar scenarios? I mean,
this case was a straight HER2 positive.
No, the first one.
The first one.
Do you give anti-HER2 or do you refer to a third center to consolidate? I mean, if you have 2 centers or 2 pathologists, whether locally or internationally, like in this case, one saying right, one saying left, I mean, what would you do?
Look, unfortunately, it's a very tricky case. I put it because of the difficulty sometimes to reach consensus in among the pathologists. But if I knew that it is HER2 heterogeneous from the beginning, then probably I would give anti-HER2, of course, as pertuzumab, trastuzumab. But I may be, skeptical to utilize TDM1 because if you have chemotherapy in your combination, it will solve the problem of HER2 heterogeneity in the HER2 low areas. But TDM1, it needs a complete expression of overexpression of the receptor to give you the best outcome. Actually, maybe the newcomer trastuzumab TXD, it works for it is designed for HER2 heterogeneity actually.
So, Dr. Hamdi, when do I suspect heterogeneity? And the question also for our
You cannot
pathologists.
suspect. It is the lab that should suspect. Although
Is there
sometimes
anything-
we provided some in a prior meeting a patient that presented with three masses in the breast, and Dr. Nuranchi took 3 biopsies, and we find HER2 positive in 2 and HER2 negative in 1. We presented this case last year. We can do updates of this case. If the radiologist took only 1 biopsy from 1 out of 3 masses, then that will not be enough. So the radiologist, at least, she has to biopsy each and every lesion, because you may have different phenotypes within this disease. Yeah. Yes.
I want to also emphasize on this point of the heterogeneity, that the radiologist would biopsy different areas, different enhancing areas if it has a different enhancement, because usually this reflects on the histology, and also to take into consideration the percentage of these different areas. Usually we say heterogeneous if it's more than 10% of the tumor cells that have this different picture. And I also want to add that when assessing different or controversial HER2, it's usually better to do multiple testing or on different areas of the tumor as much as possible. We can also do it on the lymph nodes if it has a positive lymph node in the specimen. So that's can partly solve the problem.
So yeah, so a very important message we heard now. Pathology is not only 1 biopsy. If you have multiple lesions, please, in your MDT, discuss with your radiologist and pathologist that you have to go for multiple biopsies, because it may be always the same phenotype across, but it might not always be the same. Okay, we have seen that in the first case. We have very final comments from Dr. Ashraf Salim, Dr. Hisham, and then you'll go home if you wish.
Okay, just short comments. First of all, I would like to remind all my colleagues here, we should not put the mammography aside. We are talking about MRI and the HER2 positive, but also mammography has the unique feature of detecting the calcifications, the microcalcifications, the extension of the microcalcifications. And in order to do that, we have to have a very high quality mammography. This is first point. The second, talking about the pathology, the guidelines for us to take a biopsy, we always take from the lesion at least 4 to 6 cores, true cut cores, 4 to 6. But the idea here, when I talk to my pathologist colleagues of pathology, I ask them one question: do you really examine the 6 cores, or you just put them in the paraffin block and just slicing them up, and you're looking just in a few areas of the cores, not all the cores?
بتودوا العينات فين باختصار؟ يعني هو عايز العينات اللي ببعتها لكم بتعملوا بيها ايه؟
I was just wondering. That's all.
For sure, we do examine all the cores. Yeah.
Yeah, the answer is sometimes he has to take multiple biopsies because one of them might be negative for malignancy. That's very important. And now, at least when it comes to Hermel, I wish that we have Dr. Iman, Dr. Manal, a protocol for what we do, because now in Hermel Cancer Center, you work as a sort of a central pathology lab for the whole country, where we need to do what is not really done routinely in other pathology labs. So I will urge because what mentioned by Dr. Ashraf, very important, we take multiple biopsies. The more we know about the disease, the more the oncologist, the surgeon, can do a better job for the treatment of these patients. Dr. Hisham, you have the final comment?
Yeah, it is not a comment, it's a question for you, Professor Hamdi, about two questions, actually. Firstly, do we agree as the oncology committee to omit the anthracyclines in HER2 positive disease? So we feel that the best is to start with the anti-HER2 from the beginning, with omission of the anthracyclines, the first one. And the second is, in the first case, we use carboplatin in luminal disease, and I don't know, it is unusual to go for this. I don't like we don't like to transfer a message that we can use carboplatin in the luminal, or we can use carboplatin in luminal.
No, I did not pass a wrong message because it didn't work, by the way. We don't have data, but clinically, in the first case, there was no clinical response at all for AC. The radiologist told us the uptake is less, but I mean clinically it was the same. So we thought that that's extracurricular, that's off-label, that we have to augment the remaining chemo. So it's not an indication to give carbo, and it was important to tell you that it didn't work. Okay, we tried to intensify treatment because the best treatment, part one of the best treatment, didn't work well, although it was dose dense again. So we did not have much choices, as you can see. So there is no wrong statement. It was an attempt to improve. Your question for should we omit carbo, should we anthracycline in the treatment of the adjuvant treatment of HER2 positive, the answer is if the question is why not to use anthracycline, the answer is why to use.
Not
Okay.
why not, but because I feel it is time to tell all the community, that all the scientific community, that yes, we usually omit.
We put it like this in the guidelines, but we cannot because if you tell me I'm going to give AC and taxane with anti-HER2, I cannot tell you that's wrong, okay? But I can tell you that's less safe for the heart and less safe when it comes to neutropenia. Neutropenia is not a big deal; you can deal with it. But when it comes to the heart, it is important. At least in young women, you can do that. If you wish, in women above the age of 60, it's unfair to give anthracyclines actually. But in the guidelines, we put non-anthracycline as option 1, and option 2, the classic anthracycline and taxane. Okay? We did not abandon anthracycline in the guidelines. Do you have any final questions? We don't? Yes, please. What's your name, doctor? أهلا وسهلا.
Thank you, Dr. Hamdi. I want to negotiate the point of surgical decision in the second case. As Professor Hisham said, why we didn't do just
breast-saving surgery?
Yes.
Yes. You have the surgeon, the radiologist. If they agree, I will agree. Okay?
I think it is risky as the patient is BRCA mutant, so we will have ipsilateral breast cancer risk in comparison with mastectomy versus breast conservation. As Professor Omar said, may reach up to 23% ipsilateral risk for recurrence versus 88% only if we did risk-reducing mastectomy.
I'm not sure of the figures. Can you say it again, doctor, please? What's the risk of recurrence after breast surgery?
Ipsilateral.
Yes.
Risk of recurrence may reach up to 23% in breast conservation surgery.
You're talking for the BRCA?
Yes.
Yes. That's
the
not
second
recurrence, actually. That is existence, because it can be recurrence with the same oncological meaning of relapsing disease, or it can be new primary. So you put it in your record as recurrence, but in fact it is a new primary. Anyway, the events are higher, local events. So whether it is recurrence or more appropriately second primary will be higher if you go for breast-saving surgery. But survival is the same.
Yes.
So probably I think that recurrence in itself or second primary is not a good news for the patient and for the doctor. That's why if you have the capacity to do breast-saving surgery, subcutaneous mastectomy, nipple sparing, and then immediate reconstruction. That will be
better for
better
disease
for,
preservation.
for the patient and for you as surgeon as well.
Okay, thank you.
So we don't have any further questions. Thank you so much for everybody, the wonderful faculty. Reem, thank you for the invitation, and for our colleagues in the floor. Okay.